in Lahore, a dear friend for a long time. Himself and Azam, who's a dear friend as well from Wisconsin. He's been very helpful with various things that we do here. And I'd ask the moderators to introduce Vlad.
Thank you, Salman. Today's talk on the webinar is by Professor Vladimir Binesh. He is professor and the chair of neurosurgery at the First Medical School, Charles University, Prague, Czech Republic. We have a co-moderator as Professor Azam Aslam from Wisconsin, USA. Well, both of these have been to Karachi many times, and we had an interaction with them a couple of times, and they are very much liked by neurosurgeons of Pakistan. Today, the talk by Professor Vladimir is on arteriovenous malformations. And Professor has got a great passion for vascular neurosurgery. And over the decades, he has seen the evolution of this neurosurgery on aneurysms and arteriovenous malformations. And we are very much keen to listen the master how this surgery on arteriovenous malformation has evolved over the years into this today's multidisciplinary approach with radiosurgery and embolization. So we've got a lot of participants, and I can see it's approaching 105. And I think we should just start the presentation. Over to Professor Vladimir.
Thank you very much for nice and humiliating introduction. Welcome all, and let me thank Imad for putting on the presentation, because it was really like a difficult delivery. We spent nearly a whole night together on WhatsApp trying to transfer the presentation to this place. All right, let me talk about the AVM. The presentation is divided into two parts. The first part is technical, how I do it. I hope that the videos will work, because it's rather important to convey few technical tricks and share with you what I have learned about the AVMs over the past years. And the second part will be our series plus meta-analysis, and we shall draw some conclusion how one should treat, or one could treat, AVMs at recent time. All right, Imad, can you switch it on? You are already at the, go back to the first slide, please. Yes, that's it. Am I able to control the screen, Imad?
Yes, you have the control.
Okay, so let's start with the first part about the technical things. The planning is neurosurgery is definitely the most important part of any surgery. So plan the approach well. AVMs are not the lesions for some keyhole surgery or something like a minimal invasive. Make the craniotomy large enough to see the whole nidus, provided it is on the surface. Try to perform your craniotomy in a way that the nidus will be on the surface, that you will be approaching the AVM along the long axis of the nidus, and the approach will be vertical for your comfort, for your thing. So let's see the first AVM. You see it's in the left frontal lobe, grade 1 AVM, one big draining vein, and on MR you see that the approach to go for vertical and to go for long axis, the best would be from the opposite side through the farts. So let's see the video. If you perform your craniotomy, oops, that's it. The craniotomy is on the right side. You just cut the falx, lift it, and then you see, oops, Imad, something happened to the video, doesn't matter. Let's go to the next one, where it's, and now you see that we are in the process of resecting this AVM. The approach is vertical. You see the whole AVM very clearly. You do not need to go anywhere behind the corner, and the surgery definitely is rather easy. Does it work for you, the video? No. It is the post-op angio. He jumped too much.
How long you have?
I guess the videos do not work properly. This is the post-op angio, because in any AVM you must present the post-op angio, otherwise it's not honest. You see that used was the flow-related aneurysm which disappeared within a year. We never treated this aneurysm. The next case, it's exactly the same, but in the occipital region. And again, the approach is from the opposite side through the falx, and you get directly to the nidus. Your approach is vertical along the long axis of the nidus. So this is the pre-op, and this is the post-op angio. So that's the first technical trick I wanted to show you. Large enough craniotomy, I mentioned already that, well beyond the nidus margins. Have at least 2 centimeters of the margins between your craniotomy and the nidus. The first step is opening the dura. In AVMs, this is not like opening the dura anywhere else. There are frequent adhesions between the nidus and dura, especially between the veins. The veins probably have some propensity to grow into the dura. So open it carefully, check for all the adhesions, and then dissect the dura circumferentially. So let's see the video. That's it. Don't reflect the dura the usual way.
Why can't
the adhesions between the dura and the nidus. And while opening it, cut them sharp. Use scissors. Always scissors. Do not tear anything. Otherwise, you will tear the vessel wall. Yeah, it's very slow video. I'm usually operating a little faster. And everything is slowly cut. Now you will see that one of the vessels ruptured. If you will reflect the dura fast, you will tear it, and the surgery is done actually, because you will be in the river of blood and you will be unable to do anything logically. And here the nidus on the surface, you see that the margins to the sides of the craniotomy is quite ample to allow for any manipulation to approach it from any angle needed. So let's go forward. We are back at the beginning. Imad, can you do something about it? One back. Yeah. Study the angiography properly. We are just jumping. That's it. No. 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 Study the angiography carefully, and especially study the veins, the drainage of the AVM. You see that here. Can we get one back? No, back. Okay, keep this. Here is the main draining vein going to the vein of Labe, and here is the secondary vein, draining vein. You would expect that you can cut it easily because there is other drainage. But see what happens when I coagulate this feeder. This vein becomes dark. It means that the AVM is compartmentalized. Not necessarily the whole AVM is drained by the major draining vein. It may be drained, part of it, by separate vein. So check first, and whenever closing the vein, use the clip first. If the nidus gets swollen, just release it and go elsewhere. And that may be even for small secondary draining veins, that part of the nidus is drained only by this vein. So it's one of the points when one should be very, very careful. Next. Yeah. Always start your dissection at the arterial side. You see this temporal AVM. Here is the video that dissection starts with a simple dissection of the Sylvian fissure to see all the feeders, and only then you go to the rest of the nidus. Always starting at the arterial side, whenever possible. There are exceptions, we shall see it later. Next, Imad. Dissect the margins and arachnoid sulcal dissection. That's the beautiful part of AVM surgery. At this point, you think that you are the best neurosurgeon in the world. It's very nice and easy. You see all the vessels and everything. Then only when you enter the white matter, the troubles start. So let's go further, what it looks like. This
Sorry,
is a nice
Vlad. Sorry, Vlad.
Yes.
I apologize. I think we'll get Imad to control. If you let him control the.
I will be telling him next. Yes.
Yeah,
yes.
it will be easier then.
It will be easier.
Yeah. Okay.
Yeah, I'm
Thanks.
not going to touch the mouse anymore. Okay.
Okay. That's better.
Okay,
Yeah.
Imad, are you there?
Yes, sir.
Okay, so here's the dissection of the temporal AVM. You see that the nidus is covering the whole temporal lobe. The draining vein is actually in the Sylvian fissure. This is the dominant side, so you do not want to harm anything. So very sharp dissection and very gentle dissection, and slowly you will reflect the nidus out of the superior temporal gyrus, which actually is not involved in the AVM. The video plays very slowly. You see that
we have time. Don't worry.
Yeah, don't be lazy to change the instruments. If you have the forceps and you want to cut anything, just do not steer, go for it. Now you see the artery which is entering the nidus. It really looks like the feeder. Don't coagulate it at this point, because you must treat all the vessels as en passage arteries until proven otherwise. That's probably the most important message at this part of the lecture. And you see that the superior temporal gyrus is slowly appearing, and suddenly it's free, and the AVM is only in the middle temporal gyrus. Can we go forward, Imad? Next.
Yes, sir.
Yeah. So dissect all the en passage arteries, patient coagulation of any vessel. And when you coagulate the vessel, it's good to cut it stepwise. Open the lumen. If it doesn't bleed, then you can cut it in its entirety. If it bleeds, it's easy to coagulate. If you would cut it entirely, the stumps may retract and you may be chasing them in the white matter. And this is the general rule. Okay. Can we see next video?
Yes, sir.
Does it work?
Yeah.
Yeah, that's it. You see the tiny vessel just in the center of the screen. It's not the vessel which belongs to the AVM. You see that it's dissected. It's en passage artery, tiny one on the temporal gyrus, but you should preserve it. And this should warn you that this artery, which we have seen at the beginning, may not be the feeder, but may be en passage. And as you further reflect the nidus, you will see the bridge between the two veins. It's here. This is the vein, and the vein in the Sylvian fissure. And it's full of blood with high flow. So you need to coagulate it very patiently. It's sometimes not easy coagulated. I don't like to use those high power non-stick vipers. I usually use a regular bipolar, but I coagulate it really patiently and then cutting it stepwise. Just make sure that you do not harm the surroundings, that you really coagulate only the vessel which is at your place. Okay, let's go forward to the next one. If the AVM starts bleeding, identify the bleeding point and deal with it. Do not go forward. Do not tamponate the bleeding point. Do not leave it behind, because all these bleeding points, they have some tendency to multiply. You have one bleeding point, you go forward, you have second, you have third, fourth, and suddenly you are again in the pool of blood. So it's always, let's say, important to deal with the bleeding and preserve the en passage arteries. Again, let's see the video, Imad. This is still the same AVM. You see that I have torn the big draining vein in which was seen at the previous video, and I will not leave this unless I really deal with this bleeding. I wouldn't tamponate it. I wouldn't go forward. I would deal with this bleeding point, and I will only continue when the bleeding is quit. You see that I used the clip, and I was somehow at this point lucky enough that this clip quit the bleeding, didn't occlude the draining vein. And suddenly you see this is the artery which was there at the beginning. It's not the artery which feeds the AVM. It is the major branch of the middle cerebral artery. Should you have cut it at the beginning, you would have caused a big infarction in the dominant side. So that would be a disaster for the patient. You see that the artery only gives 2 or 3 small feeders to the AVM. On the other hand, this loop, which is now well seen, belongs to the AVM, so this may be coagulated and reflected elsewhere. And you now see that the whole superior temporal gyrus is not involved in the AVM, that the AVM is only in the middle temporal gyrus. So it's a very surface AVM and very easy to deal with once you really dissect it properly from the surrounding tissue, from the sulci. And you still are within the sulci. You see that this is all the time the sulcal dissection. And this is the true feeder which is being clipped now. Much more proximal from middle cerebral artery, of course. You would like to occlude it with a clip, then coagulate and cut. Okay, let's go forward, Imad. And this is after. Next, please. We are doing our post-op angios immediately. And the same anesthesia as the surgery is performed, the patient is transferred to angio suite, and only after the angio he goes into the ICU. So we have immediate control. Again, once more, en passage arteries until proven otherwise. Let's see the videos and you will see perfect example when not to do it. This is not really well defined nidus. Next. And this is the surgical image. And you see on the right-hand side, the artery which is going into the nidus. You would think, all right, I have a feeder, I will occlude the feeder and it will be easy to go on. Do not do that. You do not know whether this really is a feeder of the AVM. And now it's being slowly dissected. Next video, please. And you see that suddenly there appears another big artery. That's it. Which is a true feeder. That is the feeder you want to occlude, not the one which mimicked the feeder and which was seen at the very beginning. Next video, please. All right, and you see the feeder well now, and you see that the original artery is outside your dissection. This is just to show you how difficult it sometimes is to coagulate these vessels. I didn't use clip intentionally at this case. I just wanted to show how much time it takes to occlude the feeder and then again cut it stepwise, open the lumen. If it doesn't bleed, continue with your section, not any previously. Next slide, please. Imad, go forward.
Yes, sir.
And you see now, here is the bed of the AVM. The cavity is completely free, and you see that the original vessel, which looks like feeder, had nothing to do with the AVM whatsoever. Should you have occluded at the very beginning, you wouldn't help yourself and you would harm the patient. The artery branches and it's outside. Next, please. Okay, deep feeders, that is the problem, and that is what Michael Lawton calls battle. These are difficult to coagulate because they are fragile. The vessel wall is not sufficient. You have actually nothing to coagulate. So these spear ependymal feeding arteries are the important part of the section. They usually go, these typical AVMs, which are like conical shape, usually tend to go as far as the ventricle. There is the last feeder usually, which you have to seek actively and occlude, preferably with clips, as well as all those deep feeders. So let's go for the video, which will hopefully work at least in a way. Yeah, and you see the feeder, these tiny arteries, which are at the depth of the AVM, you have to reflect the nidus. They are almost impossible to coagulate. They tend to rupture, they tend to retract into the white matter, and you fight with them. The best way how to deal with them is to put the mini clip on that. There are mini clips which are dedicated to AVM. They do not hinder your approach later, or even the small aneurysm clips, and then you can coagulate and cut the feeder. At the end, you may try to remove the clips. Usually it's possible because if there is no shunt, the arteries are possible to coagulate much more easily. So you may end up with several clips. At one place, you see that I'm putting on another clip. That this is the difficult artery which is now seen. All right, let's go forward. So this is the difficult part of the AVM, and there usually is some bleeding, but try to avoid it and use clips deliberately. If you will remove them, okay. If you will not remove them at the end of surgery, nothing really happens. Imad?
Yes, sir.
Oh, did we got stuck? You see that there are probably 6 or 7 clips, and I don't know how many I have left there at the very end, but that's the way how to deal with these deep feeders.
Next.
Next. That's what I have said, that as soon as you enter the ventricle, like in this case, you will want to seek the feeder. There is 1 or 2, not usually more, going along the choroid plexus, and you would like to occlude them really active seeking, not reacting to the vessel, but active seek the vessel. Next, please, Imad. Now we are as far as the ventricle. If you have the AVM nidus, which is in the vicinity of important structures, then do have all these important structures under your control all the time of the surgery. Don't let them slip out of your sight. So this is the AVM, which is located in the flocculus region of the cerebellum. Next. And you see that on the right hand is the 5th nerves, on the left hand side is the 7th and 8th. The AVM nidus is in between them within the cerebellum, but all the feeding arteries and all the draining veins were going into the CP angle. In between these 2 tumors, big tangle of vessels there. All the time you would like to have under your direct vision the 7th and 8th and the 5th. Don't let them slip out of your sight. Keep them all the time within your line of vision. Next, please. And this is after. Again, next. Showing lots of normal angiograms. Approach along the vein is very rare, but there are instances when the vein is the only orientation point for you. Let's see the next. Let's see an example of this. This is a tiny AVM at the quadrigeminal plate, which bled. The patient did have a double vision. You see the AVM on angio. We did selective angiography, and our radiologist was afraid to embolize it because there looks that one of the perforators is en passage. I don't like to send patients with brainstem lesions to radiosurgery, so we went for open surgery. Go ahead for the video. Yeah. And this is my beloved supracerebral infratentorial approach. And you see the atypical vein, and that's the only orientation you have. ICG. I don't see too much of a use of ICG in AVMs, but it's nice, and of course it will show you the vessels properly. And then going along the vein, I just cut all the vessels which entered the vein. I didn't cut anything else because I was unable to recognize which one is the small, tiny perforating artery for the brainstem, and which one is the artery for the AVM. It was not short surgery, but I didn't see any other approach, and I wanted to preserve all the perforators. Let's see the next. And this is at the end already. There is the stump of the atypical vein, which is being coagulated as the last. And now we shall see, as soon as I will remove the nidus, which is something like 3 millimeters in diameter, as it's coagulated and charred, and the bed of the AVM, and then the ICG has some role that you see that there are no atypical arteries anymore, and you see that all the perforators are preserved, feeding the brainstem as they should. So let's see the ICG. Let's wait for that. It's a pity that the videos do not run properly, so it's not that informative, but I just hope that you see what I want to show you and that you understand what I'm talking about. And now on ICG, as it jumps in, you will see the stump of the vein. That's it on your left-hand side. Over here, a small one, and all the perforators, all the important arteries preserved. So next, let's see the follow-up angio. Okay, that's it. Next one, Imad. The next point, it's you can go directly to the nidus without better knowledge of the anatomy. So here's the bleeding in 2014. This is what we saw and what we embolized down in the on selective angiography. It was more or less like a fusiform or shunt because the vein was filled very early. Go ahead. And this is the angio in 2017, and here on the left-hand side, you see the early vein filling, and the AVM or the shunt is directly in the wall of the ventricle. So let's see the videos. You just enter the ventricle, and here you see the feeding artery, which is very tiny. It's not really that easy to find it, but if you see the bleeding, you orient according to the cavity of the hematoma, then the best orientation point is the draining vein in the wall of the ventricle, which is seen below the forceps, and you just coagulate it. And then next one, please.
Next.
And you resect the whole lesion, but this is really direct approach to the AVM without proper knowledge of its feeding and of its draining. And again, the orientation point is the draining vein, which is seen within the ventricle. Next slide. That was the end of it. So let's go forward. I hope I made my point about orientation. This is at the end of the resection. Again, the tiny AVM, but deeply seated, deep within the wall of the lateral ventricle. And as usual, the vein is cut as the last, which should be the most important part of surgery. The veins are, let's say, the reason for the disasters. Next, Imad. Next. Doesn't work? Choose the proper vein as the last. This is it. You have the last vein, but the AVM already has been dissected free, but it's still full of blood. You see, there usually is last feeder, which is going with the vein, with the last draining vein. Again, in this case, I used the clip, and only after I saw that the nidus is not swelling, I cut it to the end. Preserve the vein until the end. It sounds like very logical and the only way how to deal with the AVM. But take a look what happened when I didn't follow this rule, not willingly. That was my silly mistake, which you will soon see on the video. Easily looking AVM in the temporal lobe on the non-dominant side. Everything went well. You see that the dissection is, let's say, half done, and everything's easy, and exactly the point when you think that you are the best neurosurgeon in your vicinity, that everything's fine. And I was lazy, and I wanted just to retract a bit the temporal lobe. And you see, I tore the draining vein, the only one. This was not difficult to occlude the vein, but this is what came out. The brain is protruding out, the bleeding, the pool of blood in the AVM bed. And suddenly, from easy and nice surgery, what happened was difficult wartime surgery. We fortunately got by. This is the final resection cavity and the angio after the surgery. So be careful about the veins. Unpassage arteries and the veins, that's the important message of this presentation. Next, please. Combined treatment, pre-surgical embolization. I will start with saying something heretic. I don't like it. Whenever possible, I avoid any endovascular treatment. You then deal with the ball of rubber. You have the bleeding from occluded embolized vessels. You have the live vessels in between the glue. So it's nothing easy. And at the end, I will show you why the most important point, why I do not like endovascular treatment. So we really now use it very, very rarely. Usually in the posterior fossa AVMs like this one, go for next. So we embolized the guy. I don't know whether it was 1 or 2 sessions prior to surgery. And you see what you get. The dissection seems rather easy because there's lots of rubber, and at the beginning you dissect it very easily. When you need to reflect this AVM, then it becomes a little difficult. And usually there at the depths are those vessels which are still alive. And here in between, if it will move a bit, you see that there are still live vessels which feed something within the ball of rubber. So it really is not easy to get not only oriented, but also to deal with these vessels at the end. And you also tend to follow the veins. There was at the beginning 2 veins which were occluded by the glue, and this is what's in the vessels in the quadrigeminal region. Next, please. I will show you another case which is probably more informative. Again, post-op angio. Next case. This was an unhappy guy who was coming to us for 15 years. These were his original angios, and he got cerebral symptomatology, swallowing difficulties. It was not easy. We started, I wouldn't dare doing surgery on such a case. I don't think that this would be possible. So we embolized him several times, 7 times over the 15 years. And only at this point, I said, all right, this is the time for surgery to resect the AVM. Everywhere is glue, only the part of the AVM which is fed by the posterior inferior cerebral artery is alive, so it should be easy. Now we are at the top of the AVM, at the top of the embolized nidus, and you see that very soon you will see it, just now. It's bleeding rather profusely and rather without any hesitation. So you all the time are within the blood. You see that this was the time when I really used high powers and strong bipolar. Here is the embolized draining vein. And you see that it's still bleeding. It's not occluded. There is the rubber within the vein or onyx. It's still bleeding. And of course, it's pretty difficult to coagulate the onyx along with the patent part of the vein. So it's really nothing which helps that much. But in this case, it was indispensable. Let's go to the next, what the bottom of the AVM nidus looks like. You do not get any good orientation. So this is the part which is in the tonsillar region. And you see that it's surgery within the blood. You really do not know where is the proper margin of the AVM. Where are those arteries which are still alive? Where are those which are embolized? It's really nothing that pleasant. And this is 15 years after the diagnosis. This is at the end of surgery. Fortunately, the AVM is resected. Fortunately, we were able to control all the bleeding, and we didn't harm the brainstem and the posterior inferior cerebral artery trunk, which is now seen here, and the brainstem or upper cervical cord. And we really were able to remain within the cerebellum only by pure luck, as I feel it. Next, please. Again, post-op angio, that we finally, after 15 years, solved this case. The post-op CT is completely useless with the glue within the cerebellum. Next. I believe that that's him. Next one, please. He even had gamma knife treatment, which didn't help much. So this is the beginning of treatment. Next, I get that this case is there twice by mistake. Jump through. Next. Imad. My mistake. I apologize. Next. These are the same videos again. And next. And the AVM is solved. I'm sorry that I didn't show you. This is about the ICG and how you can use it at the very end. You can cut the vein and you have nice milky surgery. It's fun for everyone after the resection. So you may enjoy ICG, but the help of ICG in my mind is not very important in AVMs. Next, Ima. Elective and emergency surgeries emergency surgery, in this case, you see the nidus well, you see the hematoma. So you can resect this AVM directly, but be prepared that you will not get oriented yourself what is what, because it's all obscured by blood. So the resection of the nidus is more or less blind, and you just resect the area where the nidus is. This is after. Next. There are these cases, but as much as possible, I try to avoid them. So here there are the 20 points technical which I wanted to share with you. Large enough craniotomy, AVM on the surface, along the long axis, open dura carefully, very important. Correlation, begin at the arterial side, logical but sometimes forgotten. Arachnoid circumferentially, of course. And passage arteries, most important part. Patient and thorough coagulation, cut them stepwise, use mini clips, don't hesitate. Non-sting high power, I use only very seldom, but it's really individual. Identify and deal with any bleeding before further resection, that's important. Along the vein, very exceptional, important structures under the control all the time. Extreme care with deep feeders, these are the difficult ones. Choose the proper vein as last, check all the veins all the time. ICG, you can use it if you don't want, you don't get too much info with it. Coagulation, cut the last veining drain, of course, and thorough hemostasis, general neurosurgery. Okay, let's go forward. Do we have time for the second part of the lecture?
You're talking about aneurysms or?
No, AVMs.
AVM, but how long would you like to talk?
Another 20, 25 minutes. Depends if people are exhausted or not, bored.
Can you switch on, Khalid? You want to do another talk maybe some other day? Because, you know, how long have you been talking? Half an hour?
It's up to you. I don't know how much time you have dedicated. I can show you my worst case now at the end of the surgery, and then we can have at some other day only the clinical part. Only
I think what we should do is take some questions from the participants.
So let me show you the disaster. People like disasters, okay?
Yeah, okay.
So this was a female of 15 years, and she came to me with epileptic seizures. Next, Imad. And this is the AVM, and on MR, it looks very compact nidus. And this is the angio where I failed to appreciate the pathological vessel around this compact nidus. Next, please. You will see the functional MR, all right, all the functions are away. So I discussed this with the girl and with the parents, and they opted for surgery. Next, please. I was stupid enough to offer them surgery. They were stupid enough to agree with surgery. Here you have more treatment modalities. You may embolize something. You may even send her to radiosurgery. Next. But I got to surgery, and this was the last good image of surgery. From this point on, when I started the dissection, it started bleeding and bled and bled and bled. It took me some 7 hours, and I then ran away. Next, please. Oops. And this is 6 hours post-op. You see the number of clips left there. You see what it looks like. Next. The girl was sedated, ventilated. So I didn't have any idea about the clinical condition. This is what it looks like on day 1. We performed decompressive craniectomy, then several revisions with resecting of malactic tissue. Next. This is what it looks on 6 post-op day, 14 days post-op. You see that it's still protruding, huge infarction in the watershed zone. Next. The girl is still on ventilator and on sedation. 6 weeks and 2 months when finally the edema subsided. Next, please. This is the angio which is still dreadful, even 6 weeks after surgery. The only good thing is that AVM is not anymore there. We are talking the year 2007, and since that time, I'm very, very careful. Next, please. And this is 8 months postoperative MR. You see the infarction. And the last slide, the huge infarction. The girl ultimately is severely hemiparetic. Next, please. She's got communicative disorders, which is strange. She's able to communicate, and she even studies some university. You see here the perinatal, the neoangiogenesis into which I ran, and I was unable to leave it to get farther from the nidus. It was bleeding, bleeding, bleeding. Next. So she now is severely hemiparetic. She has rather good communication. She studies or studied a while ago. She competes in Paralympic bicycling. That's the only good thing. And you see that loosely translated, her name was Miss Bedluck. And I was stupid enough that not even this did not alert me that I'm running into a big, big problem. Okay, that's it for today. This is what will be published, hopefully, and this is what we published. And like now comes the clinical part, which we probably can have at any other day. Salman?
Yeah, I think let's take questions, and we can do this in 10 days' time, the clinical part.
Yeah. The clinical part, right. Fully agree. It's too long.
Yeah.
So,
I would just like to start off. It was a wonderful presentation by Professor Vladimir. What would be your criteria for selection for surgical treatment of AVMs? How would you
like selection criteria? I didn't hear the whole question, but selection criteria for surgery. It's very easy. Grade 1 and grade 2 Spätzle-Martin scale is definitely surgical treatment. With no respect to presentation, with no respect to patient's condition. Majority of these patients are very young. I shall show it in the clinical part. It's very easy to understand, and it's very clear in my mind that these are the surgical lesions. No other treatment modality should be used in these cases. Grade 3, it's a heterogeneous group. Then I would operate on large AVM, which is on the surface. Small AVM, which is in the depth, I would treat radiosurgically. And in grade 4 and 5, I wouldn't opt for any active treatment unless the AVM is bleeding repeatedly. The observation is the safest approach for these AVMs, since anything you can offer to the patient is more dangerous than the natural course. Did I answer your question?
Yeah, okay. What would you do for asymptomatic grade 1 and 2 aneurysms, AVM, sorry. Spätzle-Martin grade 1, asymptomatic AVMs.
In patients, say below 60, I wouldn't hesitate offering them surgery. No other treatment. In patients who are 60, 70, I would think probably about surgery versus radiosurgery, but most likely and most frequently, we offer them observation. And in older patients, I wouldn't do anything because this complication rate, which is negligible, still you cannot beat the natural course. So younger patients, all surgery, no other treatment.
We'd like to pass on to
about the. Oh, sorry, there's a question about the timing of surgery for ruptured AVMs. How do you decide on the optimal timing of surgery for patients who have ruptured AVMs?
That's one of the most difficult questions. If you see the nidus well on the on your CT angio and CT, and if it's accessible, if it's small, if it's dissected by the hematoma, then I go ahead straightforwardly provided the clinical condition of the patient calls for that. But then, as I said, the resection is a little bit blind, because in a field which is covered by blood in subarachnoid space and everywhere, you are unable to recognize which vessel is which. So you just resect the area where the AVM is. So I try to avoid this. There are even cases where we evacuated the hematoma from the distant parts, opposite part of the hematoma from the AVM, and we risked the rebleeding and then waited for 3-4 weeks when it cleared. But most of our patients are treated on a regular elective basis. When I get a patient with an AVM and he's in a good condition, I talk to him, I show him all the images, I show him all the statistics, and then I send him home, and he or she should decide himself. Coming back to me in 2 weeks, then we decide for final treatment, and then we go for it. So emergency only rarely, but you can do it, of course.
There is a question regarding the management of intraventricular AVMs. How do you manage these, especially in the presence of hydrocephalus?
If there is hydrocephalus present, we do not treat the hydrocephalus first. We treat the AVM first, and only then we deal with the hydrocephalus. And most of these AVMs are located on in the vessel wall of the lateral ventricle. And if you imagine how to approach it, the best approach is through the contralateral side and through the region of the frontal or parietal gyrus entering the lateral ventricle. Using navigation and using the gravity, it's really, I had a nice video about that, which I didn't include in this lecture, but it's really surprisingly easy. And when there is a little hydrocephalus, then definitely the ventricles are large and you have space enough to deal with these AVMs. Actually, if you enter the ventricle, you suddenly encounter surface AVM because it's on the surface of the ventricle.
I'd like to ask my own questions. I have a couple of questions, if that's okay. First of all, it's a really wonderful presentation, in particular the pearls that you have in there. I think that one of the very important concepts is approaching the AVM along its long axis, even if it means taking a contralateral interhemispheric approach, which is a very good approach for many AVMs. In your series that was recently published, a large series, about a quarter of the AVMs were embolized for cure in that cohort. How did you decide on those patients to be embolized for cure? Seemingly, those would be the grade 1s and 2s, which you're advocating treating surgically, which were cured with embolization.
Yeah, I understand that. That's a long answer to that. We started with endovascular techniques in 2000 for all aneurysms, AVMs, and everything. We were very enthused about the embolization of AVMs, but slowly over the next decade until 2010, we came up that it's not really that effective. Even with Onyx and even with highly selected AVMs, our success rate was like 35%. And I will show in the clinical part that this is not enough. You really do not change the natural course in the whole cohort of patients. So we actually quit the embolization as a definitive method. We don't do it anymore. Because those AVMs, which are easy for embolization, are even easier for surgery. There is very, very tiny subset of AVMs which can be treated endovascularly and cannot be treated surgically. The complication rate in our hands is lower for surgery than for endovascular treatment. The endovascular treatment as pre-surgical method is, I don't like it. because of the technical reasons, because you deal with the ball of gum, and you deal with huge veins which are full of glue, so it's not really that easy to handle it. And if you have AVM surgical experience, you really give a better job in embolized AVMs. So recently in our hands, endovascular treatment, it's posterior fossa AVMs, large ones, which we have no other option but to start with endovascular and go on with surgery. As a method of cure, we do not use embolization anymore.
There's a question regarding decision-making for grade 3 AVMs. There's, as I'm certainly you're aware, there's adjunctive classifications to discuss their marks and grading, and if you use other grading systems to help for decision-making for grade 3 AVMs.
You are right. The grading system of Spencer and Martin is not very good and not suitable for radiosurgical treatment. They have different systems, but you know, I have spent a year with Spätzle, so I'm really keen of this system, and we still use it. And actually, the grade 3 AVMs are either large ones on the surface or the small ones in the depth, usually. I'm not talking about the eloquence now. And then the decision is rather easy. Those surface ones go for surgery because you can easily approach them. And actually, there is no big difference between the small AVM and the large AVM. If it's accessible, it only takes more time and there are more vessels. But if you are patient enough, then there is no surgical difference. And for those in the depth, the gamma knife or cyber knife treatment is definitely treatment of choice. Very effective, very nice. And I really do not like to approach the AVM through the brain tissue if it's in the depth. If it's in the Sylvian fissure, all right, you can split the Sylvian fissure and convert the deep AVM into a surface one. But if you really need to penetrate the brain tissue to approach the AVM, I feel then the radiosurgical treatment is better. And I try to avoid this. Convert the AVM into the surface one. If it's impossible to have it on the surface, then go for radiosurgery. Simplified.
Okay.
Did I answer your question?
Sorry, I'm just going to interrupt here for a second. What I'd like the participants, the trainees, to fill a form which is attached, and we have put the link there, and it has 5 multiple choice questions regarding AVM. And you need to fill those and find out the best answers and solve those. And once you have that, then obviously you will discuss those MCQs at the end. The moderators will discuss that with Vlad and see, has he taught you good enough? Would you be able to answer those questions or not after this session? So, so that's your test, Vlad. So I think we'll see. So the link is there. Ahmad is going to put the link. Actually, it's there. I can see it. I can see Professor Sergio is here as well, and he's got a question. Khalid, would you be able to ask that question for us?
Yeah, I would just like to put a common scenario to you. Suppose a young girl comes in the middle of the night with a surfacing hematoma and with a deteriorating conscious level, and there is a high suspicion of AVM. How would you manage this young patient in the middle of night?
As an emergency, I would easily go for AVM if I would see it on CT angio. And those usually are small AVMs, so you could resect it during the night. No problem in that. If it would be a large AVM, I would go for decompression only. Either bony decompression, huge one, or evacuating part of the hematoma on the opposite side from the AVM. And I would go for AVM on an elective basis. I have a nice case about that, which I could show, include into the lecture for the clinical part, which would answer your question. There was a grade 4 AVM, young guy, and he had a huge hematoma. We didn't attack the AVM, which was really large, grade 4 in the central region. We just evacuated part of the hematoma and we let the guy slowly improve over the next 5 weeks. And then, only then, we went ahead for surgery, resecting the AVM. And ultimately, this boy who was really at the beginning Glasgow coma 4, then going to Glasgow coma 14, 13 with severe hemiparesis, and he ultimately recovered without any deficit now. Very, very nice case. So it is an emergency, but the emergency should either be targeted on the AVM or on the hematoma. But emergency, definitely.
Okay. What are the chances that...
Starting, go ahead.
Yeah. The CTA can miss small AVMs. If you do CTA in the middle of the night and the CTA turns out to be normal, we could just think that it's not AVM, but CTA could miss small AVMs.
Of course. We have several cases like that when during the night the resident evacuated the hematoma and only then we realized that it was an AVM. That's definitely the case. And we have a rule that if there is an atypical hematoma in a patient which is not really 80-ish, we go ahead for angiography. I still believe in angiography. I don't believe that the CTA is that a miraculous investigation. Angio really shows you. So any atypical hematoma goes for angiography unless the deterioration is really too fast. I'm just talking about CTA for orientation. You saw the case I have shown that we had CTA and that was the orientation, how to perform surgery. But we also had angiography. There was an angiography and we knew how the needles, what the needles look like.
Over to Professor Azam.
Azam, please.
Yeah.
I was just going to ask one question that I have for your experience is regarding radiation as an adjunct to surgery. For instance, in large AVMs, large grade 3s, to deal with some of these deep perforating vessels, the so-called red devils. Spetzler, or did my fellowship there, like to use radiation as an adjunct, and this hasn't gained a lot of popularity, and I was wondering if you could share your experience with that.
Yeah, that's perfectly logical, and those are exactly the questions, two questions which trouble me. If the endovascular people would be able to embolize those deep feeders, I would be using it. It would be great. But they do just the opposite. They embolize the large feeders, which you easily find and clip. No problem in that. And by that way, they are increasing the flow in the deep feeders. If they would be able to do it just the other way around, embolizing the deep feeders and leaving the main feeders behind for us, that would be ideal. It would be nice, and then I would go back again to embolization. And the next question which you hit is probably the important one. Radiosurgery followed by surgery in the failed cases. I have had 4 cases like that who came to me 3 or 4 years after the gamma knife treatment, and they still had the remnants of their AVMs. These 4 surgeries were the easiest surgeries for AVM I ever did. And no one did this intentionally upfront. No one treats AVMs this way, starting with radiosurgery and in the failed ones going for surgery. And that probably would be the easiest approach, taking time, of course. There is 3 years gap when the AVM may rupture. But still, this sounds to me very logical, and the experience from these 4 cases I have had, it really was piece of cake to resect the remnant of the AVM.
In patients with grade 4 AVMs or large grade 3 AVM, for instance, with the prenatal aneurysm, how do you decide if a patient has ruptured, what to try to treat? Obviously, there's higher risk in treating these larger AVMs. On the flip side, if you just treat the prenatal aneurysm, you may not be providing any really great efficacy if that's not the true site of the source of bleeding. So how do you approach this problem, which is relatively common, I think?
You again hit several problems. It's flow-related aneurysms and it's grade 4 or large grade 3 AVMs. You know, our gamma knife people do compartment radiation. So if you send them a big grade 4 AVM, they irradiate the half of the AVM, which suits their needs, and then in 2 years' time, they irradiate the other part of the AVM.
Mm-hmm.
Of course, it's a risky endeavor, and of course, the patient is endangered by bleeding. But still, we have several cases like that where they cured the AVM. Not many, but they are able to do that. And if there would be a remnant, you could do your surgery later on the remnant of the AVM. So that would be easy. Unfortunately, this is not done like a planned approach. The gamma knife in our city is in the other hospital, and the communication is difficult. So it's not like a protocol. But we now acquired the cyber knife, and we shall start with this protocol. And I believe that this will be a rather good approach, the staged radiosurgical treatment. Flow-related aneurysms. First, if there is a bleeding, you must diagnose if the AVM bled or if the flow-related aneurysm bled. Most frequently, it is the aneurysm which bled. Then we treat this aneurysm by endovascular means, and we go for AVM later on when the patient recovers. If the bleeding is from the AVM, then we leave behind the aneurysms unless they are close and you can clip them, and we go for AVM resection. But most frequently, it's first the aneurysm treatment and then the AVM treatment. And the treatment is invariably endovascular. No surgery for these aneurysms. And if you leave them behind, they disappear. If they didn't bleed and you have a small aneurysm on, you saw the first case, there was a flow-related aneurysm on anterior cerebral artery. It disappeared within 6 months when the AVM was resected.
Salman, you're muted, I think.
I'm sorry. Okay, just to remind everybody that participants that they need to fill the multiple choice questions, so that we'll be coming back in 5 minutes and having a look at that and see what answers we have given, and has Vlad taught us good enough? Carry on, guys, with your questions.
I'd like to just give a summary, if I can, of something that I got out of the talk. I think that number one, this is a monumental experience that we've gone to hear about, in lifetime's worth of work. Some of the key topics I think that were broached upon in this talk were, number one, a lot of the surgeries that were shown today are not for the faint of heart. Those posterior fossa AVMs that Dr. Benesh showed us are extremely challenging, with embolization, without embolization, with radiation, without radiation. However you slice it or dice it, those are extremely challenging cases. The principles of AVM surgery are easy to list on a slide, but in the thick of things, it's very hard to adhere to those principles because things get in the way. The vein gets in the way, bleeding gets in the way, where the edge of the nidus is, and in situations where there's a diffuse nidus becomes challenging. And so these are some of the nuances of AVM surgery that Dr. Benesh has mentioned. Another key thing was caution against using the MRI as a method of defining the borders of the nidus. This is always not the case. The nidus is always underestimated by the MRI. You really need to study the images ahead of time, correlate the vascular anatomy on the angiography, with the MRI, knowing full well that the nidus will extend beyond what you see on the MRI is a very, very key point that was made today. The importance of using angiography at the end. There's a question regarding what to do with residual AVMs, and that answer, I'm sure Dr. Benesh would agree, is go after the residual nidus because that may bleed. And we appreciate your honesty to show some of the difficult outcomes that you've had so that we can learn from that experience. So I'm sure I speak on behalf of all of the participants. This is a really wonderful talk, and thank you for your candor in your presentation.
Yeah.
Thank you.
Okay, so I think we will go to the answers of the questions and the questions that were there. So let's go to the, yeah. So we're just going on to the, but you're going directly to the answers. Why can't we have the questions first? Let's have the question. Khalid or Azam, can you take it away for us, please?
Yeah. So, according to available evidence, which one of the following statement is most correct regarding of arteriovenous malformation rupture during pregnancy? A, most AVMs rupture during the first and second trimesters. B, most AVMs rupture during the puerperium. C, most AVMs rupture during the second trimester. D, most AVMs rupture during the second and third trimester. Most AVMs rupture during labor. Same rate of AVM rupture throughout pregnancy and puerperium.
Next question.
Could just mark. Yeah.
Next question.
The next question is, the arteriovenous malformations are most commonly in the cerebral hemisphere, the cerebellum, the midbrain, or medulla. Just mark one. And the next one is, 25-year-old male complained of fits. The DSA showed right parietal superficial AVM measuring 4 into 2 centimeter into superior sagittal sinus. What is the special Martin grade? You have to mark it 1, 3, 4, 5. What grade is it? And the next question is, all of the following statements about formation hemorrhages are correct except 15% of AVMs have no symptoms. The initial presentation of A1, 2 of AVMs is hemorrhage. This is the anterior circulation aneurysm. And the longitudinal studies show % per year rate of bleeding from asymptomatic AVMs. And the seizures only develop after an AVM.
No sé, es que Maite no está hoy aquí. Está...
Yeah. Can we move on to the next one?
Yeah, those were our multiple choice questions. So we'll come to the answers, see what people have done.
Yeah.
Okay. Azam, would you like to go with the answer?
Is Azam there?
Azam
Yeah.
was.
Sorry, I was muted. Now I'm unmuted. Can you hear me okay?
Yep.
Yeah.
Yep. So this is a question about pregnancy with a question regarding the timing at which AVMs rupture during pregnancy. And it looks like most people thought that the likelihood of rupture was the same throughout pregnancy, with close second being during labor. So I'd be interested to hear what other people think about this, but I was sort of taught that the highest risk was during labor, but I don't have any great evidence of that. So I don't, it's just my gestalt and what I was taught. So.
Vlad, your thoughts?
I really do not know. We are not doing pediatrics, so I am not that aware of that. I would put it during labor, but it's probably not true.
Khaled?
Well, I think not labor, but it's a peripartum, you know, just immediately before delivery or maybe after that.
I don't have the answer to that. This MCQ was made by the senior registrar who's not here at the moment, so I don't have a clue. So, but I would have put it labor or peripartum. Yeah, but I don't know is the answer. So guys, we'll let you know about the answer. You know, we have to send them the certificate after this is over. It's a 2-hour CME. So once we're sending the certificate, we'll send the answers as well. And
the second question was regarding the most common location of AVMs. And far and away, people selected the cerebral hemispheres, followed by cerebellar and midbrain. I would say that this is certainly true to my experience and true to the large series that the vast majority of them occur in the cerebral hemispheres. Any disagreement by Dr. Benesh or Dr. Mahmood?
Well, yeah, I think, of course, cerebral hemisphere. I mean, it's a
cerebral
95.
hemisphere, by all means.
Yeah.
By all means.
So a 25-year-old male with a right superficial AVM measuring 4 by 2 centimeters, draining into the superior sagittal sinus only. What is the Butler-Martin grade? How about, can we unmute one of the, I think this is a very good question for health officer. Salmanbhai or Imad, do you want to pick somebody to answer this and what the reasoning was?
Yeah, sure. We can unmute Waqas. Waqas, you're being unmuted. Waqas, are you listening to me?
Amar bin Hassan,
Waqas, can you hear us? I think Waqas is an outpatient at the same time, so it seems like, so we're going to move on with somebody else. Adnan? Adnan, can you hear us? They deliberately are not hearing us. Okay. Can anybody raise hands? You know the answer to this? Just anybody raise hands? Anybody who wants to take this?
You can be the star.
So we have Yasser here, who wants to take this. Yes, Yasser, can you hear us?
Yes, sir.
Yes, so can you tell us which grade is this?
Yeah, this is grade 3 because if you see this is the 4 into 2 centimeter, which means this is going to be 8 centimeter more than 6. It's in a non-eloquent area on the right parietal, and at the same time, if you can just see that it's a young patient, so no eloquent area. So all favors a grade 3 actually. So this is a grade 3.
So you're really close. The problem is that it's not, you don't multiply the dimensions. So you go based on the longest dimension in general. Some people take an average of the 3 measurements, but in general, it's the longest dimension. So this is a grade 2 AVM. It's non-eloquent, so it gets no points for that, no deep drainage. So I would call this a grade 2 AVM.
No, but it's parietal. It's parietal, it's eloquent. It's parietal.
Right parietal.
Yeah, it's eloquent.
Left.
No, but
I would consider that not so eloquent.
Right parietal is not considered eloquent?
I would not.
So apart from frontal lobe, what are the non-eloquent part of the brain?
I mean, and this is a debatable point that you're bringing up. You know, it depends on who you ask with regards to what one would consider eloquence. And even at my time at the Barrow, Swetzer kind of would modify and hem and haw some of these definitions of eloquence. But certainly, we'd consider motor function to be eloquent. We'd consider things in the brainstem would be considered as eloquent function. The lambic locations would certainly be considered as eloquent. And then usually people don't include vision and visual pathways unless it's involving occipital pole as eloquent. Usually the consideration of the optic radiations are not considered eloquent in general. Left parietal, I would consider eloquent regarding the issues with calculation math, etc. But I'd be interested to hear Dr. Benish's opinion regarding that.
Yeah, this is very difficult. The eloquence is difficult. When Spitzer constructed his scale, it was motor area, Wernicke's area, Broca's area, occipital. But he never ever stated whether it's within or adjacent. And what is adjacent? You know, so it's a very relative factor, the eloquency. People tend to grade them higher up to get better results. So they operate quite a lot of grade 3 AVMs. The one is measuring 4 centimeters, it's grade 2, it's not grade 3. And really in the cerebral hemisphere, the eloquency, it's motor, Wernicke, Broca. That's it. Not the visual cortex, which is strange to me, and I consider visual cortex to be highly eloquent, and I always put the point when it is within, not adjacent, because we have sulci.
Okay, so I think we got the answer to the first question as well regarding pregnancy, and the rate is same throughout the pregnancy.
Mm-hmm.
So let's move on to the next question.
So all of the statements are correct, with the exception of people picked seizures only develop after AVM bleeds. I would agree with this being the incorrect statement. As we all know, seizures can occur despite not having bled. And so certainly non-hemorrhagic AVMs can cause seizures, and it's a very frequent mode of presentation.
Okay, brilliant. So we have the feedback now on the presenter. So Vlad was judged by the people who are listening. And can you take us through, Azam, through this?
I am not sure what the scale is.
Quality of evidence.
I would assume that 5 would be excellent.
Yeah.
And the 40 people didn't quite watch the presentation. To see what was going on. So the quality of the content, 60% thought that it was a 5, 35% thought it was 4. Again, I think it's, you know, in a presentation, what you want is not just regurgitation of what is already available and easily accessible in the literature, but some personal experience and gems regarding management and personal experience. I thought that this was really excellent from my standpoint. We'd like to hear the same presentation again. Overwhelming number of people said absolutely, so I agree with that.
So that's the end of the.
Actually, in our educational system, 5 is the worst. Fortunately, you have it the opposite. Thank you.
Okay, no, Vlad, it was excellent. You know, really, it was my, you know, our pleasure to have you, and Khalid and Azam.
No AINE o AINE.
Pablo, hello.
No AINE no existe.
Hey, Pablo.
El AINE es no esteroideo.
Pablo doesn't hear us. Pablo.
Sorry?
How are you, Pablo?
Can you hear me?
Yes, we all can hear you. There are 100 people who can hear you.
No, I was with a patient in the outpatient clinic. Do you hear my conversation with her? Sorry for that. I got a call. I missed the last 3 minutes.
No, it's fine. We thought we'd just tease up upon you, and see what you're up to.
Thank you. But I have to say that I follow all the lecture from Vladimir Benes, and it was awesome as always. As always.
Okay, brilliant. So I think
that is always, Pablo.
Well, that's almost always. And can I ask you something, Vladimir?
Yeah, sure.
Something
Sure.
very brief.
Go ahead.
Have you ever sent a patient for radiosurgery with a big feeling inside you that probably it will not work?
I did. I believe that the patient is the one who should decide. It's very individual. And if the patient tells me that he wants to go for radiosurgery, and I don't believe that radiosurgery is the best option, I respect his wish. I do. But during the discussion with the patient, I, of course, don't let him decide that much. I tend to guide him to the treatment modality which I believe is the best. And I can tell you, I don't like radiosurgery too much. There are AVMs which are definitely for the treatment, but if they irradiate patients with grade 1 and 2 AVMs, that's a sin. I don't like it. I don't like it. Grade 1 and 2 are said is a surgical disease. Do resect them because it's not really that difficult. And you saw Aruba. I don't want to go into that. Aruba is a good example how not to design the protocol, how not, it's the worst ever randomized trial. I have been part of it and I never ever found a patient to randomize. But still, Aruba showed me that grade 1 and 2 patients should not be treated by radiosurgery or endovascular. That's my conclusion from Aruba. Don't treat these patients with radio gamma knife or endovascular.
Thank you, Prof.
We can have a big lecture about Aruba. No problem in that, Salman. But I better talk about the clinical experience and meta-analysis. That's important and nice next time.
Okay, definitely. I think we will have your clinical session in about 10 days' time. We'll let you know the date. And Khaled, Azam, and Pablo, it's a pleasure having you all. If you can see on the screen, Professor Yoko Morotel, everybody knows him. He will be talking about MIS surgery, noontime, same time on Friday. And on Saturday, we have actually a WFNS spine committee as well as IFNE webinars. Along with that, we have another webinar from Naren's group in listserv. And then on Sunday, we have Greg Trost talking about, from Wisconsin, Nazem, your place, talking about, he's going to show some cases on Sunday. And we also on Sunday have Hassan Sayed from Virginia, who's going to be taking us through evaluation of a pediatric neurosurgical patient. So guys, you can see it on the, so we should be able to connect, and we'll hopefully have you back and all of you back soon. Azam is also scheduled for next week. So, and Pablo is going to be coming back soon in 10 days time as well. So we will have all of you and you're going to have a lot of fun. Okay, guys, it was a pleasure having you. Vlad, again, was brilliant. Thank you.
Thank you.
Thank you.
Thank you.
It was a
Thank you,
pleasure.
Vladimir. Thank you, Salman.